Hello dear friends, how are you doing today? I hope we are doing well. Today we are going to talk about secondary syphilis. Definition: the rash of secondary syphilis represents an inflammatory response in the skin and mucous membranes to the hematogenously disseminated treponema pallidum spirochetes. Clinically, the rash may appear in various ways, but the most common is scaling papules and plaques. Incidence: despite the availability of penicillin, secondary syphilis is still present in our society and its incidence has been increasing in recent years, certainly in the general population, but disproportionately more so in men who have sex with men and people with HIV. History: the secondary phase of syphilis starts 6 to 12 weeks after the appearance of the primary chancre. The chancre has usually but not always healed by the time the secondary phase develops, but it may be remembered by the patient. Systemic symptoms are usually present and they include fever, headache, myalgia, arthralgia, sore throat, and malaise. Pityriasis, once thought not to occur in secondary syphilis, is noted occasionally. Physical examination: the rash of secondary syphilis is a great imitator. It may appear as a macules, non-scaling papules, and annular plaques, scaling papules, patches, and plaques, and occasionally pustules or nodules. Vesicles or bulla are not present, however, except in newborns with congenital disease and occasionally in patients with HIV. The most common lesions are scaling papules and small plaques, in which the color is a clue. Lesions are most frequently not just red but rather reddish-brown, hemp-colored or yellowish, copper-colored. The eruption is often generalized, but palmar and plantar involvement with lesions of these colors is particularly noteworthy. Other possible mucocutaneous features include white mucous patches in the mouth, condylomata lata, which are flat-topped and moist, wart-appearing lesions in the genital areas, and spotty alopecia of the scalp, which has been described as moth-eaten in appearance. The general physical examination usually reveals the presence of lymphadenopathy. Secondary syphilis characteristic: palmar and plantar heme-colored reddish slight scaling patches and macules. Secondary syphilis: in epidermis, slight hyperkeratosis is present, and in dermis, perivascular infiltrate with lymphocytes, plasma cells, and spirochetes with a silver stain can be seen. Differential diagnosis: as mentioned, the rash of secondary syphilis can mimic many other skin disorders, the most common of which is pityriasis, rosea, as has been discussed, drug eruption, viral exanthem, and sarcoidosis for the annual lesions seen especially in black patients. A general guideline to remember is that for patients with a generalized rash of unknown origin and systemic compliance, secondary syphilis should be considered and the patient should be tested for it. The conclusion of differential diagnosis of secondary syphilis include pityriasis, rosea, drug eruption, viral exanthem, and sarcoidosis. Note: the rash of secondary syphilis is a great imitator. Involvement of the palms and soles suggests this diagnosis. Note: in patients with fever and rash of unknown origin, a serologic test for syphilis should be done. Laboratory and biopsy: in secondary syphilis, the non-treponemal serologic test for syphilis or STS or PR or rapid plasma regain or VD or L or venereal disease research laboratory are always positive in immunocompetent hosts and usually present in high titers. The treponemal specific test or FTA-ABS or fluorescent treponemal antibody absorption test and TPEIA or treponema pallidum enzyme immunoassay are most specific tests for syphilis. Screening can be done with a treponemal specific test or TPEIA and then confirmed with a non-treponemal test. The positivity of these two blood tests secures the diagnosis. False positive tests, usually in low titers, occur in some patients with SLE. The STS may be negative in a patient with coexisting HIV infection and secondary syphilis. If syphilis is suspected in this setting, a ductal examination or biopsy or a skin lesion can confirm the diagnosis. This procedure visualizes the spirochetes in serous fluid obtained from the lesion or in spatial stains or biopsy material. The histologic findings are otherwise frequently non-specific, showing simply an inflammatory infiltrate and in lesions with scale hyperkeratosis and mild acanthosis. Plasma cells are often present in the inflammatory infiltrate and may suggest the diagnosis. Patients diagnosed with syphilis should also be tested for HIV infection because the presence of the former indicates a risk factor for acquiring the latter. Therapy. Penicillin remains the treatment of choice for syphilis. For primary and secondary syphilis in immunocompetent hosts, a single intramuscular injection of 2.4 million units of benzathine penicillin G is adequate therapy. HIV-positive patients require more intensive therapy, either with benzathine penicillin injections weekly for 3 weeks or with a course of intravenous aqueous penicillin or intramuscular ceftriaxone. Immunocompetent patients who are allergic to penicillin may be treated with a 14-day course of either tetracycline 500 mg QID or doxycycline 100 mg BID. With therapy, many patients experience a febrile reaction or so-called Jerish-Herxheimer reaction beginning within 12 hours and resolving within 1 day. The conclusion of therapy for secondary syphilis: initial therapy include benzathine penicillin G 2.4 million units IM. Alternative therapy include doxycycline 100 mg BID or tetracycline 500 mg QID for 2 weeks. Note: in patients with HIV, syphilis progresses rapidly and requires more intensive therapy. Course and complications: without therapy, the lesions of secondary syphilis resolve spontaneously in 1 to 3 months. In immunocompetent patients, with therapy, the lesions resolve promptly and the titer of the non-treponemal STS is reduced markedly by 12 months. The treponemal specific test often remains positive indefinitely. In the secondary phase, the treponemal organism spreads not only to the skin but also to other organs. Hepatitis occurs in approximately 10% of the patients, bone and joint disease in approximately 4%, and nephritis even less often. Central nervous system or CNS involvement is reflected by abnormal cerebrospinal fluid findings occurs in approximately 10% of immunocompetent patients, but is much more frequent in patients living with HIV, in whom rapid progression to symptomatic neurosyphilis may occur. Approximately 1/3 of untreated immunocompetent patients develop years later complications of syphilis or so-called tertiary syphilis, of which the most important are the cardiovascular and central nervous system or CNS manifestations. In people with HIV, progression to tertiary syphilis is more frequent and can occur within months after the primary infection. Pathogenesis: the disease is caused by the spirochete T. pallidum. The organism is traumatically inoculated into mucous membranes or skin, most often during sexual intercourse. After a 10 to 90-day incubation period, the primary lesion appears as an ulcer or so-called chancre. After another brief latent period during which the organism continues to multiply, hematogenous dissemination occurs, or so-called secondary syphilis happens. Organisms infecting the skin provoke an immunologic response, which is clinically manifested by a variety of inflammatory lesions, as we discussed above. Clinical case: a 27-year-old man presents with a 2-week history of a generalized non-itchy skin rash. He reports a low-grade fever, malaise, sore throat, and weight loss. He also mentions a painless genital ulcer that appeared about 6 weeks ago and healed spontaneously without treatment. On examination, there is a diffuse symmetrical maculopapular rash involving the trunk, face, palms, and soles. There are mucous patches in the oral cavity and condylomata lata in the perianal region. Generalized lymphadenopathy is present. The rash is non-pruritic and polymorphic in appearance. What is the most likely diagnosis? A. Pityriasis, rosea. B. Viral exanthem. C. Sarcoidosis. D. Drug eruption. And E. Secondary syphilis. According to our explanation, the diagnosis is secondary syphilis. Key diagnostic clues: history of painless chancre or primary syphilis, generalized maculopapular rash, palm and sole involvement, mucous patches, condylomatous ladder, generalized lymphadenopathy, systemic symptoms, and non-pruritic rash are all key diagnostic clues of syphilis. While the others are unlikely, pityriasis rosea presents as a single herald patch and distributes with a Christmas tree pattern without palms and soles and without mucous patches. Viral exanthem is usually pruritic or febrile illness in children without a genital history or mucous patches, and sarcoidosis, papules, plaques, lupus perennial, systemic granulomatous disease without palms and soles rashes, and drug eruption is pruritic temporal relation to medication without mucous patches or condylomatous ladder. Okay, this was a short explanation about a secondary syphilis. Thank you for your attention. Hello dear